Yeah.
So here we have the masters. Amit Prasai is our colleague who spoke to us on day one as well. So Amit's going to talk about these very important X-rays, salivary stones and other imaging for the mandible and the mouth. So over to you, Amit.
Yeah, thanks, you. Almost there. So over the next sort of 30 minutes, I'll go through the role of different modalities that are available in imaging the oral cavity, mandible, and I'll talk a little bit about major salivary gland obstruction and how we investigate these. But I'll keep it relevant to what we do in ENT. Yep. Now, I suppose the thing to consider is when you see somebody who's got some sort of pathology within the mouth or mandible, is to think what the condition could be. Yeah? So if you sort of categorize them broadly into sort of congenital and acquired conditions. So, with congenital problems, you've got the vascular anomalies, you've got the developmental abnormalities. I think we come across lingual thyroid every once in a while. Inflammatory, a whole host of conditions that have been covered over the last few days. And you get benign soft tissue tumors, malignant conditions, and I think trauma obviously forms a big part of maxillofacial on-call work. And the next thing is, what's available. So plain radiographs have been going for over 100 years. Conventional sialography, ultrasound scans, CT, including 3D reconstructions available now. Various forms of MRI scans, and in some places they're doing MR sialography as well. And obviously bone scan, PET scan, and angiography is also available. Now I go to for the first case, which is this patient here, and I think you can see there's a swelling in the right floor of mouth, and I'm sure you guys all know what this is. This is a ranula. Yeah, so I'll probably come across it once or twice a year. It's usually a sort of a painless swelling in the floor of the mouth. You've got two options. The first is a CT scan, and this is normally how it looks. So it's a dense area. Because the wall is really thin, you don't often get the enhancement around the wall of the cyst. And you can, the nice thing about a CT scan is it will tell you the anatomical location. It might it might point towards which way you're going to excise this, either transorally, or if it's into the neck, maybe through the neck itself. Yep. On MRI scan, you'll get, particularly on T2, which is the key, you get high signal intensity because it's fluid and it's a bit like sort of water, I suppose. And you get low signal intensity on T1 weighted images. So the next one is lingual thyroid. Seen probably about 3 of these in my ENT career. Again, it's normally, you can see them either on, when you get them to open their mouth, or certainly you should see them on flexible endoscopy if it's sort of small. And it has a sort of classical appearance. Even, those of you who've done thyroid surgery, this is what the capsule looks like. Yeah, so sort of quite vascular. So for that, the CT with contrast usually gives you the diagnosis. We've got quite a big vascular anomalies MDT in Leeds, which I sort of chair once a month, and these are sort of quite fascinating, the types of conditions that we sort of encounter, and depending on what your suspicion is, they're a really challenging group of patients to treat, and most of the treatment is based around interventional radiology sort of techniques. But in terms of imaging, there's a whole host from ultrasound scan, CT, MR. Because it's mainly soft tissue tumors, MR with angioretinography, and sometimes we use conventional angiography as well. So these are a group of conditions that are quite difficult to manage. So this next case is a 60-year-old chap who's been referred by the 2-week wait cancer pathway. He's got this big ulcerated exophytic lesion on the ventral part of the tongue, which also involves the floor of the mouth, anterior floor of the mouth as well. Smoker, sort of a heavy drinker as well. I think one of the key things when you see people like this is to, initially just think of T&M classification, particularly the T. You want to be able to, see what the size of the tumor is, and obviously also, does it involve any of the sort of the nerves? So a good clinical examination, and then you're already thinking about, how we're going to manage this. So is this going to be a curative sort of management algorithm, or is it going to be more sort of palliative? So when you see these lesions, I think my first take-home message is assess them clinically. Even if it means getting a ruler out to measure the exact size of it, it's probably worth doing. Now, investigation-wise, what do you want to know? So that's the key, and give the radiologist as much information as possible, because then the report will be based on what you've put down on your request form. So the first one is the extent of the tumor, which is radiological staging. If you are going to operate, it might provide you with what you call a surgical map, and it will help decide treatment options, because if it's a small tumor, even if it's a large tumor, if it's a free flap, then obviously your decision is important, and obviously MDT discussion will be carried out. Now, the first investigation is plain radiographs, which are quite easy to obtain. Its only use, certainly in this day and age, in that scenario, is to look at the teeth, really. So if you do see somebody with a sort of any cancer, I suppose, that's going to need radiotherapy, it's worth getting a OPG to start off with. We've got a sort of a dental surgeon as part of our MDT, and in fact they run a parallel clinic next to us, so it's not so important. But certainly if you work somewhere else where you think there may be a delay, just arrange a OPG, which will speed up the process. It's not really there to look at if the bone's involved. It's not sensitive enough, so you can't really plan your management based on plain radiographs, except to pull certain teeth out. So this is what an OPG looks like, and you can see here, so this is a big sort of tumor, and it's all like what you call an apple core type lesion, and you can see if you follow the cortex down, there's a loss there, and there's a big punched out lesion that you can see. So that's squamous cell carcinoma of the mandible. In terms of assessing the oral cavity tumors particularly, MRI is the choice, but you may need both in certain circumstances, particularly if you suspect bony involvement. So the difficulty with imaging is when you do 2-week wait clinics, is if there's something obvious, you should really get all the investigations as soon as possible, because there's a timeline. So you've got 2 weeks to see the patient, 31 days to get a diagnosis, and 62 days for them to start their treatment. And sometimes it can be challenging. It can take up to 2 weeks to get a CT or MRI scan. So if you see them initially, if you suspect a cancer, just arrange your imaging. Now, CT is obviously mainly for better for bony definition, even looking at sort of early cortical erosion. MRI is obviously far better at looking at soft tissue, so base of tongue, tonsil. And obviously bone scan, and certainly we don't tend to arrange bone scans as part of the cancer pathway, but certainly a PET scan we do quite regularly. There is enough enough literature on looking at what's better, and I think the consensus is that MRI is far better at soft tissue. Although in some centres we've got a far better MRI scanners or more powerful ones, I think they're just as good as looking at early cortical erosion. So it depends partly on on your radiology department. Certainly where I work, we tend to get MRI for soft tissue and CT for bone. But obviously, as you get towards the sort of retromolar trigone, the CT is far more sensitive. The other issue is, lots of people have fillings, and that can degrade the images. So just bear that in mind. So this is an MRI scan. You can see on the OPG this tumor here, and you can tell the cortex has been lost, and the marrow itself is replaced by tumor. Yeah? So this is a T1 weighted image with contrast. So that's looking at the tongue tumor. So this is a lateralized tongue tumor, and get used to looking at these images in the three planes, because what that gives you certainly for me as a surgeon is it gives me how much I need to resect. So you can tell on the axial plane here the tumor probably doesn't quite reach the midline. On the coronal, you can see the extent, and whereas if you look at the sagittal section, it goes quite deep. Yeah? So often the TNM stays, the T side of the staging has changed slightly, looking at oral cavity tumors. So they also look at the depth of the tumor now, which wasn't there before. So these images are quite useful for discussion in the MDT. PET-CT, obviously the standard is for investigating unknown primary, but also pre and post treatment for non-surgical treatment. So that's what we tend to do in our MDT, and also recurrence. Yeah? So those are the areas where you tend to get a PET-CT scan. So the other issue is when you see tumors in the mouth or floor of the mouth or tongue or within the oral cavity, is do you do a biopsy before you get the scans? It just depends. I think if you see a small tumor, it's probably worth getting the imaging beforehand. But if it's a big tumor, I don't think it makes a huge difference. But certainly, because you do get a bit of edema, and if you arrange an MRI scan after a biopsy, it often you get a bit of edema, so they often upstage the T side of TNM. And also there are 3D reformats these days. They give you lovely pictures. I think the definition's not as great, the anatomical definition, but certainly it gives you nice pictures like this. And I think if you're doing reconstructive work, it can be helpful. And obviously for trauma as well, it can be helpful. So plain X-rays for evaluation of fractures. I think most weekends in most maxillofacial departments, there'll be a queue of people waiting to go to theatre for treatment of mandibular or maxillary midfacial fractures. And you need two planes as well. Just remember that, because on this OPG film, I mean, you can sort of there's a step here if you follow the cortex, but it's much more obvious in the other plane. Particularly mid-face, if you suspect there is a fracture, then I think imaging with CT is far better as well. Yeah? But certainly for mandibular fractures, I think they tend to be happy with just doing plain films. And obviously, after you fix the fracture, you need another film to make sure that it's all in place. Plain radiographs are also useful for looking at cysts within the bone. So third case is somebody who's presented with sepsis in the right neck, unwell. Clinically, you suspect an abscess. And I think my my advice would always be, if you see a abscess within the submandibular, submental, or anterior neck, just look at the teeth, and get an OPG as well. And there's a reason why that is, because majority of submandibular abscesses are related to the teeth. Yeah? And also, in terms of imaging, what questions do you want to ask? You want to look at the source of the infection. Is it an abscess? And where is the abscess in relation to the surrounding anatomy? OPG, again, it's useful in detecting dental abscess. Ultrasound is good, but I think from my talk on Friday, I think the gold standard for deep neck space infection is CT scan. Submandibular abscess, I think in small children, if you don't want to, particularly if they need a GA for a CT scan, I think ultrasound is reasonable. But certainly, if you suspect something in the parapharyngeal or retropharyngeal abscess, then you probably do need a CT scan. But certainly in the submandibular space, I think ultrasound is reasonable. So this is somebody who had you can see there's something happening within the submandibular space, on the left here. And if you look, I don't know, this is with sort of contrast. So I don't know, there's something leading up. I don't know if you can see this, leading up to the mandible. Yeah? So I don't know if you can appreciate that on the big screen, but there is a tract leading up to the mandible. So, and here you can see there's a little bit of cortical loss. So this is somebody who presented with a submandibular abscess, which obviously needs draining. But to look at the teeth, it didn't look too bad. But certainly the CT scan shows that there's a little bit of cortical loss, which you can see there. And if you look at the OPG, there's a little bit of loss of bone around the second molar here. Yeah? So, and the thing is, you could drain the neck abscess, but you've not really sorted the source of the problem, and it needs sorting out. So, and if you're not used to, they often don't get reported, the OPGs. So if you're not used to looking at them, get one of your dental SHOs, to have a look. They're good at picking up abscesses. Here you can see. So if you look at the root of the tooth, you can see a lucent area around it, and that's usually quite easy to pick up in the lower teeth. But as you go towards the maxillary side, it can be a bit more tricky because you've got sinuses, and the anatomy is a bit more complex. Yeah? But here in the molar here, you can see a sort of a shadow around the root. So, take home message again. So if submandibular abscess, think teeth. Max fax review. Get an OPT, or let them decide what they want to get. With abscesses, these abscesses can be quite tricky. If you want to drain an abscess, you want to drain all the sort of different various cavities. So if they have got loculations, you want to be able to break them down. So consider CT with contrast. Now move on to major salivary gland obstruction. So I'll present two cases which are slightly different, and hopefully that will highlight the various pathologies that you see. So first one's a 70-year-old lady, diabetic, hypertensive, recently sort of unwell, and while she was in hospital, I got asked to see her because she developed a swelling, in the region of the right parotid. Yeah? So when I examined her mouth, so this is where the parotid duct opens. She's got no teeth, obviously, but it's opposite, lateral to the second molar. So you can see a little bit of pus. So when you massage the gland, you can express a little bit of pus, which is visible there. Yeah? So 70-year-old, elderly, unwell recently, presents with pain and swelling. Yeah? So the next case is a 40-year-old gentleman who presents with mealtime, typical sort of mealtime syndrome, affecting the right submandibular gland. And in fact, when I saw him in clinic, so I got him to squeeze his neck, and you can see a bit of sort of a horrible-looking fluid coming out of the submandibular duct. Yeah. So he had an OPG, and that's what it showed. Yeah. Big stone in the right submandibular gland. So again, when you think about the differential diagnosis, are you looking at a acute problem? Is it an abscess? Yeah. And is it secondary to dehydration, or what's the risk factors? And certainly in the first lady, and that's what the main cause was. It's she was unwell, dehydrated, and then developed sort of sialadenitis. Yeah. Now, is there a obstructive element to it? Are we looking at chronic sialadenitis or mealtime syndrome, a bit like the second chap? And that's, and is that related to some sort of obstruction within the salivary flow? Is there a stone or multiple stones? Is it an autoimmune problem, or is it sialadenosis, which you can see in sort of diabetics and people who drink a lot of alcohol as well? No?
Okay, and mums as well.
Yeah, you can do. Yeah.
She's known more and more recently.
Yeah. Obstructive sialadenitis, a majority of it is stones, but you can get strictures. Sometimes if people do pass stones, you can leave them with a stenosis afterwards, because the duct itself gets sort of traumatized and you get scarring afterwards. Yeah? Foreign bodies, and incidence, I think is probably similar to what we see in Leeds. Maybe up to sort of 60 cases per million per year. And majority of the stones, as you suspect, are in the submandibular gland, and that's partly because the calcium content is higher. You've got, you have to work against gravity to secrete the saliva, and also you've got a slight kink as the duct bends around the mylohyoid. Yeah? So for those reasons, we'll probably see more in the submandibular gland, and majority, or just over 50%, are in the hilum itself. Yeah. So the key questions when you arrange imaging for these is, what do you suspect? Are you looking at, is there a stone or multiple stones? Is there a stricture, and where is it in relation to the gland itself, or the network of ducts? And also, how are you going to treat it? Yeah? So are you going to remove the stone? Are you going to destroy it? Are you going to excise the gland? So it kind of gives you an idea as to how you might treat these patients. Yeah? So that's always in the back of your mind when you arrange certain investigations. So plain films, sialography is one of the mainstay of investigations, certainly for mealtime syndrome. But it's not great in the acute setting. Yeah? So it's contraindicated. Ultrasound is actually very good for a salivary gland sort of conditions, and sometimes they can see stones. But if you've got small stones, in sort of the distal duct, then it's not great either. CT with without contrast in the acute setting is probably reasonable, and obviously MR, and in some areas they do MR sialography as well. So plain films. So this is somebody with you can see on the lateral view here, there's a parotid stone. So that's within the duct. This is a floor of the mouth view, and I don't know if you can see here. You can see a small stone there, and the oblique view here. You can see a small stone here as well. Yep. So majority of the submandibular stones are radiopaque because of the higher calcium content. Whereas, not all parotid stones are radiopaque. Yeah, so bear that in mind. Now, sialography is basically when you inject contrast material, so water-soluble contrast material, into the parotid or submandibular duct. And it's by far the best modality for outlining ductal anatomy. Yeah? So strictures and sialytids, it's the best that's out there. And the nice thing is you can also combine it with interventional techniques. So things like basket removal, they can dilate any strictures with a balloon, but obviously it has its own risks. Yeah? And you can, they're quite fiddly. So even to cannulate them sometimes can be quite tricky. So they might fail. So this is a sort of conventional sialography. You can see a contrast going into the submandibular duct, and there's a big stone. Yeah? And this is contrast refluxing within the sublingual gland here. Yeah? How do you treat that? Yeah. So this is a big stone. The treatment, we've got two options. Well, two options. One is to remove the gland or lithotripsy. But if I was to advise them, this is one where you advise them to have the gland removed. Lithotripsy, I think there's only 2 centers in the country, I think. And it's multiple treatments. To break that down, it will take quite a lot of treatments, and as the little fragments come out, it causes quite a lot of scarring. So, certainly if I was to advise them, I'd advise them to have the gland removed. Yeah. So this is one probably for basket removal. Yeah. So you can see again submandibular gland, the left one this time, and there's contrast going through, but there's a little stone here. Yeah? So this is ideal for basket removal. Yeah. This one again, you can see something within the hilum, and you've got intra glandular ductal dilatation, as you can see here, but there's a little stone there. Yeah? How would you? So it's a large hilar stone. How would you treat that? I think this one is probably more suitable for. I mean, you've got 2 options again. You could remove the gland, or this one. If you have got sialendoscopy techniques, so if there's someone within the locality that has a sialendoscope, that's one option to remove this. Lithotripsy is also another option to remove this, or remove the gland. Yeah. This is a stricture. So this is now the parotid duct, and you can see there's a little stricture here, and you've got sort of interglandular sort of ductal dilatation that you can see there. Yeah. So this would be ideal for a balloon dilatation, and then it works well. Again, this is a parotid stone. Yeah. So quite a big stone. That's not going to pass. Can be quite difficult to remove. Yeah? So you don't need to remove the gland, but if you and the way to treat them is if you raise the flap as you would for doing parotid surgery. Yeah? So raise the flap right anterior, and you should be able to feel the stone. You cut down onto it, remove the stone. That's the easiest way to remove that. Yeah. There's also these techniques of sialography, so MR sialography, digital subtraction sialograms. It's not routinely done in all centers, but there are radiology expertise in certain centers that are quite keen on them. But I think compared to conventional sialography, it doesn't give you the definition. Yeah, but this is probably emerging in certain centers. And I mentioned interventional sialendoscopy. We have got one of our Masterclass colleagues who has a sialendoscope we uses every once in a while. I think it's got its place. Quite fiddly though, as you can imagine. So to summarize, so there are sort of various modalities to assess various sort of pathologies within the sort of the oral cavity and mandible, and always be wary of local expertise, and and if you can go and learn new techniques, go and do that. just a couple of useful books. That's, you know, that's probably one of the best radiology books I've come across. That one there, Hans Berger. Yep. Okay, that's me done. Any questions?